welcome, Henry. Thank you so much for contributing to this course. And if you could just start off and share your full name and your current affiliation for us, that would be great.
Thanks, Micah. I'm Henry Perry. I'm a senior scientist in the Health Systems Program of the Department of International Health at the Johns Hopkins Bloomberg School of Public Health in Baltimore, Maryland, in the United States.
Thank you so much. And just to get our conversation launched here, could you share one highlight of your experience with primary healthcare? I know you've had so many, but just pull one out. What stands out to you?
Well, what comes to mind is not just one single experience, but a lifetime of experience working with people on the ground, trying to reach out and serve villagers and communities, and the great need that exists, but the great passion that local health workers have to help their health systems be more effective in reaching the needs of people. I've always been inspired by the difficulties that people on the ground face in trying to strengthen primary health care, because the needs have always been so great and the resources so limited. It's that reality of knowing how much people want to improve their health care and the great efforts that people make to strengthen primary health care has really inspired me over the years to keep working in this field.
So Henry, as a first question, can you talk a little bit about the major shifts that you've seen in how we think about primary health care over the years, and how these shifts are important in understanding primary health care today?
Great. Thank you, Micah. Over my career now, which spans almost 5 decades, we've been through some real peaks and valleys, of course. And in 1978, with the Declaration of Alma-Ata, there was a huge global enthusiasm for primary health care that unfortunately became eclipsed in the 1980s and most of the 1990s. Primary health care just was put by the wayside, unfortunately, and people thought of it as an unrealistic goal that had to be deferred as we address these major critical priorities that were facing the world. But now, 40 years later after Alma-Ata, people realize that the vertical approach, as important as it is insufficient by itself. And we have been moving towards this global goal of universal health care, which is supposed to be achieved by the year 2030, which is less than 10 years away now. And I think that people are finally, gradually realizing that we can't achieve universal health coverage without stronger primary health care, without a greater commitment to primary health care. And so even though we need vertical programming and they address critical priorities, that in and of itself will not be adequate. And so there's been a groundswell of awareness and need for doing more, both at the global level as well as within countries, to strengthen primary healthcare systems. And it's really exciting and encouraging to see this happen, but it's not an easy fix. It's complicated, it takes time, and it's not that easy to evaluate either, like vertical programs are. So it's a long-term commitment that's been slow in coming, but for me, it's really exciting to see where we are now at this point.
Based on all of your experience and seeing how this dialogue is evolving, what is it about a primary healthcare approach to responding to challenges and also just kind of building strong health systems? What makes that approach so effective?
Well, we can think of primary healthcare in 2 different ways, and I've been in the middle of this for a long time now. For many of us in the more developed countries, we think of primary health care as ambulatory health care provided at facilities. by highly trained health professionals such as doctors and nurses. But the Declaration of Alma-Ata in 1978 really opened the door on a much broader vision of primary health care. And that vision involves certainly what we think of as primary care in developed countries, but it also involves working with communities in collaboration and partnership, delivering services down to the household level, and involving people in the planning and implementation and evaluation of these activities, and as well focusing on equity, the needs of those who have the greatest health problems and how can we address these. And so without these components, particularly in low resource settings, but even in more well-developed health systems in high-income countries, we need this broader approach to primary health care. And one of the very many things that this broader vision of primary health care brings is a closer connection between the communities, between individual people and the health system. And it fosters a sense of partnership and, in fact, trust. And one of the great needs today that we're seeing more and more, and it comes particularly acute in the middle of our COVID-19 pandemic, is the lack of trust that people have in health systems. And without a strong primary health care system in which people are engaged and they have contact with the program, it's hard to develop that.
Absolutely. And what would you say to someone who's working in public health or watching all of the challenges that we're seeing unfold today, who is maybe a bit skeptical about how primary health care can sort of fix this problem, or sort of the practicality of taking that sort of an overarching comprehensive approach when these issues are so complex, and often health systems are still organized around more of sort of a vertical program by program kind of approach?
Right. Well, my response to that is a paradigm that guides my thinking every day of my career, which I learned from my mentor, John Wyan. And we need to think of public health, we need to think of global public health as a three-legged stool. And those three legs have each a goal. So one leg is vertical disease-oriented programs, but a second leg is what we call services-oriented public health, getting basic and essential services out to people who need them. And then the third one is called community-oriented public health, the goal of which is to work with communities to help them improve their health. These latter two legs are, in fact, the heart of what primary health care is. And if we don't have a strong leg for these last two components of public health, we have a weak stool. And of course, we need vertical disease-oriented programs, but we also need these other two. And to me, the great challenge for primary health care is to build these other two legs so that we have a strong program of public health that really is optimally effective in improving the health of the population. And we have a long ways to go in that, but it's exciting to see that we're beginning to realize the importance of this more broader approach.
What would you like to see going forward in terms of the field of public health and sort of the integration of this approach and vision for primary health care?
Well, one of the great things we need is more money for primary health care all around the world, and this is true in the United States, but it's also true in virtually every country of the world. Hospitals have sucked up a major portion of the healthcare dollar in so many countries, including the United States. And we haven't invested in primary health care like we should. The World Health Organization has recently called on all countries to expand their investment in primary health care. And in a major way, they're calling for countries to expand this investment by 1% of their gross domestic product just in primary health care. And so this is a step forward, I think, because we haven't paid enough attention to how much we're actually spending in primary health care. And there's so many examples historically and continuing up until today where an excessive amount of money has gone into hospital services without an appropriate investment in primary health care. And then also within the primary health care dollar, we need to start measuring how much of that dollar is being spent for community outreach versus services provided in health facilities. And I've never seen any studies that look at this, but we need to start calculating this because we know that the outreach services that reach out to the home are so powerful in terms of changing household behaviors and in promoting appropriate utilization of healthcare services, and even in providing healthcare in the home by community health workers who've been appropriately trained to provide family planning and to manage and treat serious childhood illness, and even give immunizations and many other services that don't have to take place in a facility.
As a final question, is there anything else that you would like to say to learners who take this course at the International Institute for Primary Healthcare in Ethiopia and are really working to understand the primary healthcare systems that are already in place in their country and how to strengthen them, especially in light of the COVID pandemic?
I'd like to encourage all the students to look at this moment as an exciting one. We've faced so many challenges and disappointments, and there's so many needs out there that are unmet. But with a new vision of what primary healthcare can achieve if it's appropriately supported and has the outreach services down to the community in the home with community health workers that we know can do so much to improve population health, we can all make an exciting difference in improving the health of people around the world who suffer needlessly from readily preventable or treatable conditions and are dying from these things every day. I'm also encouraged by the fact that we have a Director General of the World Health Organization, Tedros Adhanom, who grew up through his professional career practicing primary health care, developing and implementing a national model primary health care program in Ethiopia that includes strong community outreach and community engagement and reaching every home. And it was through his experience and leadership that Ethiopia was able to make the dramatic improvements that they've made in their population health. And for him to now be the Director General of the World Health Organization and providing leadership in all of this is really a major step forward because we haven't had that. And of course, I'm excited about the International Institute for Primary Healthcare in Ethiopia, which is an outgrowth of Dr. Tedros's pioneering work, and the Minister of Health who followed him, Dr. Kaseti Birhan. And it was their vision to share the experience with Ethiopia with others around the world who want to strengthen their own primary health care program that has made the Institute possible. And it's been a great thrill for me to be a small part of the early stage of the development of this institution, which I hope will be an important contributor to the primary health care movement throughout the world in the years to come.
Fantastic. Thank you so much, Henry. Thank you for contributing to the course, and thank you for all of the good work that you do.
It's great to be a part of this, Micah, and thanks for inviting me. And we wish the students all the best in their learning at present and also in their future work.